Hello everyone, welcome back to my channel. So those who haven't subscribed yet, please do subscribe so that you will get notified whenever I take videos in future. So in this session I am planning to take a topic known as scalp. It's very important for undergraduates, whether it is MBBS, BDS. You can get essays from this topic, you can get short notes from this topic, you can get draw diagrams from this topic. So it's very important, but it is very easy as well. Now we will move on to the topic scalp. So what is it? It is that area of the calvaria which extends from posteriorly, this is the external occipital protuberance, and this is the superior nuchal line. So posteriorly it extends from the external occipital protuberance and the superior nuchal line, and it covers the calvaria and reaches anteriorly up to the supraorbital margin. So that is the extent antero-posteriorly from the supraorbital margin posteriorly up to the external occipital protuberance and the superior nuchal line. And to the sides, till where does it extend? So to the sides it extends up to the zygomatic arch on either side. So that area of the calvaria is covered by the region known as scalp. So what are the layers of scalp? So in order to study the layers of scalp, it is very easy again. The mnemonic is the spelling of the scalp itself, S-C-A-L-P. So how many layers are there? 1, 2, 3, 4 and 5. So 5 layers are there for the scalp. So let's see what are the layers one by one. So first I will say which are the layers by the mnemonic. S stands for skin, C stands for connective tissue, which is a very dense connective tissue. A stands for aponeurosis, otherwise known as Gallia aponeurotica. L stands for loose subaponeurotic layer, or which is made up of loose areolar tissue, and P stands for pericranium, or it is actually the periosteum of the skull. So these are the 5 layers which we get in the scalp. So let's see one by one and what are the specialities of these layers when it comes to the scalp. So first one, skin. You know, the skin of the scalp is very thick and it is having plenty of hairs, sweat glands, sebaceous glands. So though we say the layer is thick, doesn't mean that it belongs to thick skin. It is thin skin with hair, but it has got lot of blood vessels, lot of sebaceous glands, sweat glands. So it is more prone for having sebaceous horn and all. Now coming to the connective tissue layer, or the subcutaneous tissue layer, which comes next to the skin. What is the peculiarity of this layer? Again, this layer we have the connective tissue which is having a fibrous network. It is a dense layer of connective tissue. And it is full of blood vessels, large blood vessels and nerves. So the large blood vessels and nerves of the scalp lie in this layer, the layer of connective tissue or subcutaneous tissue. So what are the peculiarities of this layer? So because of the dense connective tissue, this connective tissue is actually getting attached to the walls of the blood vessels. So you can imagine a blood vessel like this, and the connective tissue, the fibrous network, is getting attached all over the walls of the blood vessels. So what happens is, whenever there is a cut for these blood vessels in this layer, normally what happens, whenever there is a cut in a blood vessel, it will contract on its own, and as a result the bleeding will stop. But for scalp, what happens is, because of the connective tissue getting adhered to the walls of the blood vessel, when there is a cut in the blood vessels are not able to shrink on its own or contract on its own. So it will remain open, and that is the reason why whenever you get a wound in the scalp, it will bleed profusely. That is very important point to be noted. The reason is the connective tissue is getting adhered to the walls of the blood vessel. That is the reason for profuse bleeding. Another condition is you will get severe pain whenever there is an injury to this layer. The reason is again because of this dense connective tissue, this layer is unyielding. Unyielding means whenever there is a fluid collection inside, the tissue won't yield according to the collection. So what will happen? The tissue will stay in that position itself, and whenever there is a fluid collection, the pressure inside will build up. That is, the pressure in this layer will build up, and you have lot of nerves there. So the nerves will be compressed and there will be severe pain. So that is the reason for severe pain. The connective tissue layer is very thick and unyielding whenever there is a collection in this layer. Now the next thing is, we have already mentioned that the scalp is rich with blood supply. So when you get avulsed scalp, that is, if you after a road traffic accident or so, if you get a major portion of the scalp avulsed from the skull, if there is a very small pedicle, if you stitch it back, it will heal very completely. That is one of the important points, that is, the rich blood supply ensures vitality of the scalp layer. So these are the three important points which you should think whenever you think about the second layer, the connective tissue layer. It is rich with blood vessels, and hence there will be profuse bleeding when there is a cut in the blood vessels due to the adhered fibrous tissue layer all over the blood vessel. Then you have severe pain because of the unyielding nature of the second layer. Then because of the rich blood supply, the vitality is ensured after an injury. Now coming to the third layer, that is the aponeurotic layer or gallia aponeurotica. So this aponeurosis actually connects the epicranius muscle. So what do you mean by epicranius muscle? So epicranius muscle, they are actually two groups. One is occipitofrontalis group and the other one is temporoparietalis group. So from the word itself we can actually imagine where these muscles lie. So the first one is occipitofrontalis. So it is in a way related to the occipital bone and the frontal bone. So let's see the occipital bone, the occipitalis muscle first. So occipitofrontalis is made up of two bellies. One set is the occipital belly and the other one is the frontal belly. So occipital belly actually arises from this. So this is the superior nuchal line from the external occipital protuberance. So the occipital belly arises from the lateral two-thirds of the superior nuchal line and also from the mastoid bone. These are the mastoids. So the occipital belly of the occipitofrontalis arise from the lateral two-thirds of the superior nuchal line, and so that in the median plane we can see that they are diverging. They are not coming in close contact, and these get attached to the gallia aponeurotica, that is occipital belly. Now coming to the frontal belly, so here we mentioned occipital belly as arising from the bone, but when we come to the frontal belly of the occipitofrontalis, we can see that this is arising from the skin and subcutaneous tissue around the eyebrows and root of nose. So it is not having any bony attachment and the two bellies are closer. So that is the reason why when we discuss about the fourth layer, we will be discussing about the black eye or raccoon eye. We will come to it later. So this point you have to note. Occipital belly is arising from the bone, whereas the frontal belly is not arising from the bone. It is arising from the subcutaneous tissue nearer to the supraorbital margin or the eyebrows and root of nose, so that it blends with three sets of muscles seen in this region. One is procerus, you get the procerus here, then you have the corrugator supercilii, and the third one is orbicularis oculi. So these fibers, the frontal belly will be actually merging with the fibers of procerus, corrugator supercilii and orbicularis oculi. So these two frontal bellies will also get attached to the gallia aponeurotica. So the gallia aponeurotica connects the frontal belly and occipital belly. And coming to the sides, you have the temporoparietalis muscle. So here is the temporoparietalis group. Here the temporoparietalis is taking its origin from the gallia aponeurotica. When we discussed about the frontalis and occipitalis, we mentioned it as getting inserted or attached to the gallia aponeurotica, whereas the temporoparietalis, which we see on the sides, that is actually arising from the gallia aponeurotica and getting attached to the root of the auricle or ear. And it is actually seated between auricularis anterior and auricularis superior. In that gap you get the temporoparietalis. So ultimately gallia aponeurotica, the aponeurotic layer, connects all these muscles. Now coming to the injury to the gallia aponeurotica. So to the gallia aponeurotica you can get either a transverse cut or a vertical cut. if there is an injury in the form of transverse cut, what will happen is the occipital belly when it contracts, it will pull the cut from behind, and if the frontal belly contracts, it will pull the aponeurotic part towards the front, so that the wound will gape. But when there is a cut, when there is a vertical cut, what happens is there is no much gaping and it will heal faster. So that point also you have to remember. So the transverse cut gapes because of the pull from the occipital and frontal bellies. And one thing which I would like to say here is all the three layers, the skin, the subcutaneous tissue, which is the connective tissue layer, and the aponeurosis, all together 1, 2, 3 act together as a single layer, and they move as a single layer over the pericranium with the help of the fourth layer. So let's see what is the fourth layer. So fourth layer is actually made up of loose areolar tissue. And what is the peculiarity of fourth layer? So there are a lot of things to be remembered in the fourth layer, because fourth layer, we can say that posteriorly it is limited by the attachment of occipital belly. So before that, I would like to add some more point. The Gallia aponeurotica attachment, though we mentioned that the bellies are getting attached to the Gallia aponeurotica, posteriorly the Gallia aponeurotica is actually getting attached to the external occipital protuberance, and above the superior nuchal line we have the highest nuchal line. So on to the highest nuchal line as well. So posteriorly the Gallia aponeurotica is limiting the scalp region by a bony attachment, whereas the Gallia aponeurotica in front is actually merging with the muscle layer, and so there is no bony attachment for Gallia aponeurotica, so that the skin of the scalp is actually continuous with the skin of the eyelids. So the subcutaneous tissue is continuous with the subcutaneous tissue of the eyelids. So let's see what happens whenever there is an injury in the fourth layer. So whenever there is an injury in the fourth layer, or whenever there is bleeding or inflammation into the fourth layer, the fluid will accumulate, and due to gravity, what happens is it can fall backwards and forwards. The fluid can droop backwards or collect backwards or forwards. Backward collection, it is actually limited by the bony attachment. So it will come forward and it will reach up to the eyelids, because it is continuous with the skin and subcutaneous tissue of the eyelids, because there is no demarcation, since there is no attachment for the frontal belly and the Gallia aponeurotica to the bones of the frontal bone. Okay, so that is the reason why whenever there is a fluid collection in the fourth layer, the loose areolar tissue, that will actually gravitate into the eyelids, and there will be pooling of the fluid, and as a result, after 2 or 3 days of trauma, you can see a blackening appearing around the eye, and that is known as black eye or raccoon eye. Raccoon eye means of panda's eye. If you Google, you can see the pattern of eyes of panda or raccoon. So that is the reason why it is known as black eye or raccoon's eye. Now the next thing is, this layer, we can see that the emissary vein, so this is the skin, this is the dense connective tissue, then this is the aponeurotic layer, and this is the loose areolar tissue. So you can see that the emissary veins are traveling through the loose areolar tissue. So whenever there is a cut in the emissary vein in this layer, again there is communication between the scalp as well as the sagittal sinus, the dural venous sinus inside the cranial cavity. So what happens, I would like to add some more points for the emissary vein. Emissary veins are veins which are devoid of valves, and they connect the veins of the scalp with the veins of the cranial cavity. So that is the one point which you have to remember. Emissary veins are devoid of valves. So when we say that veins are devoid of valves, they can travel in either direction. So whenever there is an infection in the scalp region, these emissary veins can carry this infection into the cranial cavity because of this connection to the dural venous sinus. So any infection, any mild infection in the scalp, if left unattended, it can cause infection inside the cranial cavity because of this connection. So that also you have to remember. Now another thing is safety valve hematoma. So that is, suppose if there is a head injury and there is bleeding inside the cranial cavity. So what happens usually whenever the blood or any fluid gets collected inside the cranial cavity is a very closed cavity. So whenever there is a fluid collection inside the cavity, it will build on its own and there is no way out. So what will happen? The brain will be compressed because of the increased oozing out of fluid or blood. So there will be compression of brain, and as a result the brain death can occur, and there will be maximum insult to the brain tissue. So what do you mean by safety valve hematoma? Suppose in children, as a part of skull injury, there will be a fracture of the pericranium as well, the skull vault. The pericranium, there will be sometimes a fracture as well. So what will happen? Through the fracture, if you get a fracture for the bone as well, through the fracture the blood will ooze and will collect in the loose areolar tissue. So loose areolar tissue is a yielding type of tissue. So it will go on collecting the fluid which is coming in this layer. So this actually, the breakage of bone will actually help the fluid from accumulating inside the cranial cavity, and it will prevent compression of the brain tissue, so that if an accident occurs, you will get time to take the patient to the hospital because of this safety valve hematoma. So that you will get enough time to interfere, or else what will happen if there is a road traffic accident, if there is a bleeding inside the cranial cavity, say within 1 hour or so, the blood will accumulate inside the cranial cavity and it will compress the brain tissue, and the entire tissue might die off. But if there is a fracture of the skull, along with it, through the fracture, the blood will ooze out and will go on accumulating in the loose areolar tissue, and it will prevent the compression of the brain tissue, and by the time you reach the hospital, you will get enough time to treat the patient. That is why if you get a fracture, that condition is known as safety valve hematoma. This acts like a valve to ooze the blood out. Now another thing is cephalohydrocele. If you get a fracture, along with that if you get the dural tear as well, what will happen? The CSF from the subarachnoid space will ooze out, and the collection of fluid, collection of CSF, you call it as cephalohydrocele. Now you might have heard about another condition known as caput succedaneum. What do you mean by caput succedaneum? You might have seen a lot of newborns. So newborns usually after vaginal delivery, they might have some bump over the cranial vault, is minor swelling. It looks like a Pope hat. So what is that? That is nothing but when it comes through the vaginal canal, there will be a collection of venous blood around. If it is taking a longer time for the delivery, there will be collection of venous blood, and that is the reason why there is a soft swelling developing at the cranial vault. So that is known as caput succedaneum, and it is not pathological. It will go off on its own and there is no treatment required. But cephalhematoma if present, that means there is fracture of the bone and there is bleeding inside or bleeding outside. So we have to actually differentiate between caput succedaneum and cephalhematoma. Caput succedaneum is a normal thing which you get in a vaginal delivery, but cephalhematoma is a pathological thing. These two things you have to differentiate whenever you see a swelling. Now coming to the last layer, that is pericranium. So this is the bone. This is the bone with the pericranium or periosteum, and this is the endocranium or endosteum. Endocranium or endosteum. This is actually the developing from the endosteal layer of the dura mater. And we can see that this is the suture between the skull bones. So the pericranium and endocranium or periosteum or endosteum, these two layers are continuous at the suture line. What I would like to add is, if there is a fracture of the skull, so suppose if there is a fracture of the skull and the blood from the cranial cavity is oozing out into this layer just below the pericranium, and if the pericranium is intact, there is no tear for the pericranium, what happens is the blood will be actually limited to the shape of that bone, because it will be limited at the suture lines. It will not cross the suture line and go to the next bone. So the collection will be limited along the suture lines and the swelling will appear in the shape of that bone. Suppose if you get a tear in the parietal bone, and if there is bleeding from the cranial cavity, that blood will collect below the pericranium if the pericranium is intact, and ultimately that swelling will take up the shape of the pericranium, the parietal bone. So that is how you differentiate between the collection of fluid beneath the pericranium and the collection of fluid in the loose areolar tissue layer. Because loose areolar tissue layer, you will get a diffuse swelling because there is no bony attachment between the external occipital protuberance and the eyelid. Okay, so it will be a diffuse swelling. The fluid will go on collecting throughout the shape of the skull, but in case of fluid collection beneath the pericranium with the pericranium intact, the collection will be limited to the suture lines, and the collection will take up the shape of that bone. So if it is in the parietal bone, the shape will be according to the shape of the parietal bone. So that is about the different layers of scalp in a nutshell. Once again, skin. The next one is dense connective tissue, then you have the gallia aponeurotica, the aponeurotic layer, then you have the loose areolar tissue, and you have the pericranium. And some of the clinical aspects we discussed: why you get profuse bleeding, why you get severe pain if there is a swelling in the scalp, then what is the use of having a rich blood supply. Then we mentioned about the cut in the aponeurotic layer. If there is a transverse cut, there will be gaping because of the pull of the occipital and frontal bellies. Then we mentioned about the emissary veins, they are valvulus, hence the fourth layer is known as dangerous area because the infections can spread into the cranial cavity. Then the black eye due to the attachment of the frontal belly to the skin and the subcutaneous tissue which is continuous with the eyelid. Then cephalohydrocele if you get CSF collected, and caput succedaneum, which is a normal condition in newborns during vaginal delivery. And if the pericranium is intact with a fracture beneath, you will get the fluid collection or the blood collection in the shape of the skull bone. So this is about the different layers of scalp. In the next session, I'll be talking about the blood supply, nerve supply, and the lymphatics. So keep watching. Thank you so much.